Within the Wharton's jelly of the umbilical cord, the arteries are located lateral of midline in the inferior portion of the cord, positions 5 and 7 on the face of a clock. In a full-term infant, the artery is approximately 7 centimeters from the umbilicus to where it joins the internal iliac artery. The umbilical vein is a larger midline vessel with thinner walls, located at position 12 on the face of a clock. In a full-term infant, it is 2 to 3 centimeters in length and 4 to 5 millimeters in diameter. After the procedure has been explained and consent obtained from the parent or parents, review the records and examine the patient to confirm that there are no contraindications to catheterization. In your examination, concentrate on the anatomic landmarks. You must then decide how deeply to place each line. The umbilical artery catheter, or UAC, can be placed in a high-lying position between thoracic vertebra number 6 and 9, or in a low-lying position below the third lumbar vertebral body. Here, we will describe the procedure for the placement of each type of catheter. There are many acceptable methods for determining the appropriate depth of placement. To calculate the depth for inserting a high-lying UAC, multiply the weight in kilograms by 3 and add 9 centimeters, then measure and add the length of the stump to this value. To calculate the appropriate depth for the umbilical vein catheter, or UVC, insertion, multiply the weight in kilograms by 3 and add 9 centimeters, divide that total by 2, then add 1 centimeter. Standardized graphs for determining the depth of catheter insertion are available, and they are included in the supplement. To ensure the highest level of sterility, the operator should wear a sterile gown and gloves, as well as a surgical cap, mask, and face shield. In addition to these items, most of the equipment can be found in commercially prepared kits and should include skin preparation solution, a surgical drape with central opening and or sterile towels, sterile 4x4 gauze, a 3-way stopcock with a luer lock, one for each catheter port, a 5 or 10 milliliter luer lock syringe, one for each port, a number 11 blade scalpel, saline or heparinized flushing solution, straight iris scissors, 3 mosquito hemostats, 2 smooth curved iris forceps, 1 toothed mosquito hemostat, an umbilical tie, suture, and a needle driver. There are numerous types of umbilical catheters from which to choose. A 5 French arterial catheter should be used in infants weighing more than 1.2 kilograms. A 3.5 French arterial catheter should be used in infants weighing less than 1.2 kilograms. Arterial catheters should have a single hole and be as non-thrombogenic as possible. The umbilical vein catheter should be 5 French for infants weighing less than 3.5 kilograms and 8 French for infants weighing more than 3.5 kilograms. Consider using a venous catheter with side holes when the catheter will be used for exchange transfusion. Otherwise, venous catheters can be single or double lumen and should have one hole. The infant should be placed in the supine position on a radiant warmer. The infant's arms and legs should be secured to avoid movement that might contaminate the sterile field. Sedation is generally not needed because the skin is typically not cut or punctured with a needle. Make the necessary measurements to estimate the depth of catheter insertion. After you are fully scrubbed and garbed to perform the procedure, attach a stopcock to the hub of each catheter and fill the system with flushing solution. Be sure each stopcock is in the off position. Ask an assistant, who need not be wearing a sterile gown, to grasp the cord by the cord clamp and apply traction vertically. Apply antiseptic solution to the cord and surrounding skin. Apply sterile towels or surgical drape in such a way that the patient's face is visible, then wrap the cord tie around the base of the umbilicus and tie with a single knot. The knot should be tight enough to prevent bleeding from the cord, but loose enough to allow the catheters to pass through the vessels of the cord. Cut the cord horizontally with the scalpel, approximately 1.5 centimeters from the skin. Take care not to cut the skin that is at the base of the cord. Ask the assistant to remove the cut cord and clamp from the field. To insert an umbilical vein catheter, with your non-dominant hand, grasp the cord with the toothed forceps. With your dominant hand, using the mosquito forceps, remove any blood clots from the entrance of the vein. Using the mosquito forceps, introduce the pre-flushed venous catheter attached to the stopcock and syringe into the lumen of the vein and insert 3 centimeters. Gently pull back on the syringe to ensure blood return and proper placement. If blood returns, continue inserting the catheter to the predetermined depth. Obtain radiographic or ultrasonographic confirmation of the catheter position. The ideal position is in the inferior vena cava, near the right atrium. Secure the catheter as you did for the arterial catheter. If the catheter meets resistance before it reaches the predetermined distance, it has most likely entered the portal system, become wedged in an intrahepatic branch of the umbilical vein, or doubled back on itself. In these circumstances, pull the catheter out of the vein approximately 4 centimeters and rotate the catheter as you reinsert it into the vein. Occasionally, this will allow the tip to slip through the ductus venosus. Often it is necessary to repeat this maneuver several times. During an extensive resuscitation, it may be necessary to obtain emergent intravenous access. Immediately following birth, the umbilical vein is the vessel of choice. The procedure is altered slightly from what has been previously described. Prepare the umbilical cord with an antiseptic solution. It is often impossible to create a sterile field in an emergency situation. The operator should don sterile gloves and keep the catheter as sterile as possible. The catheter must be pre-flushed and attached to a stopcock and syringe. If an assistant isn't available, you can tie the cord at the base with a cord tie and cut the umbilical cord 2 centimeters above the skin. Quickly insert the umbilical venous catheter into the umbilical vein to a depth of 3 to 5 centimeters below the skin. In a full-term infant, check for blood return and secure the catheter between your fingers or with tape. It is imperative that the catheter not be inserted too deeply, as it may enter the hepatic vessels, in which medications administered during the urgent situation could potentially cause hepatocellular damage.